Well, good morning, everyone. Good morning, and thank you so much for joining us on this rather wet and miserable Monday morning here at the Christie. We really do appreciate your support, and this is for the first of these spotlight events this year, and in fact the first since COVID. So we're really pleased to be starting up this series again, and for the first one to have such great interest. So we really do appreciate your support. Thank you. So I'm Bod Buckby. I'm a patient and a trustee here at the Christie, and it's my pleasure to introduce today's event. You're going to hear from our leading clinicians about the latest work and everything that has been learnt about melanoma over the last 10 years or so. And you'll also be hearing a little bit about the work of the charity in helping to improve patient options and improve the patient experience. Today we'll be hearing from Professor Paul Lorigan, who is Professor of Medical Oncology, and Dr. Rebecca Lee, who is Medical Oncologist, Clinician Scientist and Senior Lecturer. And we'll also be hearing from Deborah Kane, who is our patient expert, to share her story. And with that, I will hand over to Professor Lorigan. Paul.
Thank you, Bod. I'm just going to try and get my slides up here. Perfect. Thank you. So to just add to Bod's welcome, so thank you for coming along on this wet and dreary Monday morning. It's a great pleasure to be here, and an honour really to have so many people come along. What we're going to try and do is give you an overview of melanoma, and we did a spotlight. It is 10 years ago actually. And a lot has changed since then. We've had a lot of progress, and I'm going to tell you a little bit about that. We've got a number of challenges as well going forward. So I'm really pleased to be joined by Deborah Kane, who I've known for many years. I'm not going to introduce Deborah anymore because I feel I can't speak for her. She speaks far better for herself. But I think she really epitomises and summarises a lot of our achievements and challenges that we've had. And Deborah's also been a great supporter of us for many years, so we're delighted to have you here. And then my colleague Rebecca Lee. Rebecca is a consultant oncologist, so a medical oncologist like myself, but she's also one of those rare breed of what are clinician scientists. In other words, she's a clinician and a scientist. And she spends a lot of time in the lab, 4 days a week in the lab, actually working in London at the Crick Institute, and then 1 day a week with us in Manchester. She did her PhD here in Manchester, and she is transferring back to Manchester hopefully in the next year or so, like 2025. So she'll be with us full time then. And Rebecca's going to, we call her Becky, so I'll call her Becky, is going to give you an overview essentially of a lot of the trials work we're doing and the challenges we have. So I'll just start with just a little bit of summary, just to remind you. So melanoma, it's a cancer of the pigments producing cells in the skin, and the incidence is rising. We've over 16,000 new cases a year in the UK, and that's continuing to rise. And that makes it the 5th most common cancer in women and the 6th most common cancer in men. And like all cancers, it's more common as we get older. But one of the peculiarities of melanoma is there is a young peak. And in the sort of 15 to 45-year-old age group, so when people are finishing, well, in education or finishing education, starting families, starting professional lives, moving through their careers, there is a peak of melanoma there as well. And that clearly has a major impact on those people and also on society in general. We've achieved a lot in terms of curing patients with melanoma, and we'll talk to you a little bit about that. But we still do regrettably have nearly 2,500 deaths a year in the UK from patients with melanoma, from people with melanomas. So a lot of work we have to do yet. So we've got 85% of people cured, but not everyone. And the other interesting point is that, in general, melanoma is a preventative cancer in that many or most are related to sun exposure. Now, that's not to blame people, if you've to say that if you hadn't been out in the sun that you wouldn't have got melanoma, but we do know there is a link between ultraviolet and melanoma, and so it's for us to try and understand better how to reduce that risk for people. So thinking about what we do here in Manchester at the Christie, I think it is true to say we've got patients right at the centre of what we're doing, and I hope that comes across as Becky and I are talking. And I think of this as our sort of discovery treatment cycle. And if you look on the right-hand side of the slide, we have an idea and we try and develop that in the lab and see if that's something with a line of sight to the clinic. And if that is, then we look at it in more detail and we move it into the clinic. We do what's called translational research. That's translating the idea from the lab into the clinic. And that is with patients. And Becky's going to talk a bit about how we do that. And then if that signal comes up to proof, if we think, yes, we've got something here, then we do a bigger clinical trial to try and evaluate that, compare that with our standard of care. And hopefully that leads on to an approved treatment. So the treatments we're using today were the experiments we were doing 5 or 10 years ago. And our standard of care now, we're constantly then trying to improve on that. So we're going back saying, well, what better can we do? So that's a very simplified version of what we do. So what do you need to do that? Well, you need a number of things. You need cutting-edge facilities and buildings. And I think you can see we are very fortunate. I was talking to some people outside. We're very fortunate in Manchester, really, in the infrastructure we have with our new building across the road, with this building, and then all the work we do at the Christie as well. So we do have the facilities and the buildings, and a lot of that has come from charitable donations. The team, this probably should be one of the biggest parts of the slide, actually. So the team is critically important to deliver what we can do here. And that's a team of scientists, clinicians, and then support admin staff to help us do our research and run our clinical trials and bring forward our treatments and then support patients through those, through thick and thin. And I'm delighted now there are quite a number of people from the team here, so I'm going to embarrass a couple of them. I can see Dr. Hurlstone there. So Dr. Adams, one of our scientists, so working in the lab. Kerry Marie is just sitting across from him. So Kerry, again, one of our very brilliant scientists as well. I can see Dr. Tim Cooksley up here in the top left-hand corner. So if you're ill because of any treatment we do, Tim is our expert, and you'll see Tim when he comes in. And I can see at the back here, the research team, you can all put your hands up at the same time. So Becky, Brandon, Abigail, Chris, and Emily, so who run the trials for us, actually. So we do, we have a big team, and this is just a small group of the people who are involved. We have a lot of patient involvement. We work closely with patients, and we're always keen to get ideas and support. So any trials we're developing, we develop with patients. What are your priorities? Are we doing this the right way? Is this an acceptable way to do it? And keen to continue in that vein. And we need money and resources, and we have a lot of support from a lot of different areas, but we get a lot of support from the Christie charity. And a lot of what we're going to talk to you about today, we couldn't have done without the charity's support. So just to reiterate that. This is a timeline, it's truncated timeline of what we've developed over the last number of years. So as you can see, it goes from essentially from 2011 up to, we're into 2024 now. And prior to that, you can see there were hardly any developments. There was, no advances in the treatment of melanoma. And since then, you can see on the top and on the bottom all the treatments that have been approved and approved in different indications for melanoma. Now, we're proud that we were contributed to nearly all of those trials, and people here in the audience will have been part of those trials. We want individuals to benefit when they go into a trial, but there is also a selflessness in a lot of people who say, you know, I want to be part of the trial for the greater good, and we're very grateful to you for that. And when we're talking about new trials, we say what I said earlier, you know, our gold standard today was our trial 5 years ago, and that's how we move forward. One of the big advances we've had has been immunotherapy to boost the immune system, and it really did start in melanoma, and it's now rolled out to a lot of different cancers, and it allows our immune system to see the melanoma and to attack it. And it's a very highly specific treatment, and we're moving forward now with a number of newer approaches to this. And I've just summarized them briefly here. So on the right-hand side, these are the sort of soluble things. This is breaking down the immune system. On the right side, we've got the sort of proteins and soluble factors, growth factors and cytokines and things that circulate in the blood. And then on the left side, we've got the cells, the T cells and other cells that make up part of the immune system. And the main priorities on the main progresses come from the bottom right, and these immune checkpoint inhibitors. These are now our standard of care. But we have very exciting new vaccines coming in. We learned a lot through COVID about vaccines, and these are going to revolutionize how we treat not just melanoma but other cancers as well. And the cell therapies is a very specialized area, but we're very fortunate we have a team here in Manchester working on cell therapies. This is a slide that shows the advances we've made in the treatment of melanoma. Now, I drew this myself, so it's what's called a survival curve, which is quite a blunt instrument, really. And if you look on the bottom, on the x-axis is time, and on the y-axis is how many people are alive from the start of the diagnosis of it. This is advanced melanoma, where the melanoma has spread. And if you look on the bottom line, the black curve, this is how it used to be 10 years ago. And very few people, regretfully, survive beyond 1 year. And what you can see now with our treatment advances is that 50% of people are alive at 5 years. And if you're alive at that, you are cured, more essentially. So you can take that as encouraging, or you can take that as actually there's a lot more to do, because there's 50% of people who are not going on to be long-term survivors. And that's really the challenge for us. And here, just to show you the sort of things we're looking at in clinic. So this is what's called a PET scan. So it's a sugar-based isotope. So cancer is very hungry for energy, and it takes up a lot of energy. And so we can label it with a radioisotope, fluorodeoxyglucose, and then we can see it. And what you can see, the top part is the brain. This is a person facing you head on. The top part is the brain. The brain is always hot because the brain is using lots of energy, so that's just normal. But you can see all in the skeleton. You can see all these little black spots, and you can see up in the right quadrant there, the sort of the liver, which has melanoma within it. And then if you look after the effective treatment, when you see the before and after, you can see how effective our treatments can be to control the melanoma. And what you're seeing here is all normal. There's the heart. The heart, again, uses a lot of energy. The kidneys and the bladder, they're the only areas that are showing up. So in terms of staging of melanoma, how do we do it? People talk about, what stage. And essentially stage 1 is where it's a primary tumor somewhere on the skin. And the majority of people with a primary melanoma are going to be cured by treatment with surgery. If it's spread to the lymph glands, it's called stage 3. And again, we expect the majority of people to not run into further problems, but we've developed new treatments to improve on that and to reduce the risk of the melanoma coming back. And for stage 4, this is where it has spread beyond the lymph glands to some vital organs, which is what I showed you on the previous. And this has been the biggest challenge for us so far. But realistically, we've made so much progress in stage 4 disease, we're now trying to improve on stage 3 and stage 2. And that's for those who've been hopefully cured by surgery, but there's a risk of recurrence, reducing that risk. And our new treatments do that very effectively. So how to improve on the challenges for us are how to improve on the efficacy of our treatment, how to get from that 50% to 100%, and how to avoid unnecessary side effects. So I haven't talked about the side effects because I know Becky is going to, but also I think Deborah is going to tell us about side effects, because these treatments, particularly the immune therapy, can cause significant side effects. And how to move from a blunt tool of one treatment for everyone, more or less, I'm exaggerating a bit here, to an individualized treatment on a person-by-person basis, monitoring them as they go, changing treatment depending on how they're responding to treatment. And these are the challenges. So I'll leave it at that. We have made a lot of progress, the treatment of melanoma. And I am proud to say that Manchester continues to be a major contributor to this. And much of that is thanks to the support of the charity, support of the people we work with. Our constant line of sight really is to the clinic. So when Becky's in the lab, she's thinking, how can we translate this into a clinical benefit? And we're working towards more effective treatments with fewer side effects. So with that, I thank you for your attention, and I'll hand over straight over to Deborah, and I'll see, Becky, are you going to do the slides? So I've known Deborah for many years, as I said, and I was really pleased that she agreed to come along and tell us a little bit about her story.
Hi. Gosh, I'm so nervous. I was diagnosed when I was 24 with a melanoma on my neck, just a very small one. And at the time, they just removed it and said I was absolutely fine, which I was for 24 years. I was absolutely fine. And then I started having problems with my vision, and went to see my optometrist, and he sent me straight to the hospital. Unfortunately, the hospital sent me away and said I had old age in my eye, and that was it. Yeah, very, very odd. I actually think it was the doctor that just couldn't be bothered, because I went 2 weeks later back to the optician because I was still struggling. And he then sent me again back to the hospital and said, you're not leaving until they find out exactly what's wrong. And I saw a really lovely young doctor, and he did a lot of tests on me and then said there's something in here that isn't quite right, so you need to have a scan. Now, unfortunately, at the time, this is 14 years ago, I found out at Christmas, and they told me at March, they said the scan would be in March, and I couldn't see. So I luckily had private medical insurance, so I jumped the queue. And they found out I had melanoma. Now, you obviously can see I'm wearing a patch, so the melanoma was in it was in the base, wasn't it, of my eye. So they had to remove my eye, but they sort of had to go in through the back and open the skull and remove my eye. Now, it wasn't just my eyeball, it was the whole thing, because I was talking to a lady outside saying, why don't you wear a prosthetic eye? The problem is I have no eyelids, so my eye, when they put a prosthetic eye in, it just stares, and my other eye is moving, so it just looks odd. And to be fair, I've been wearing a patch 14 years now, and everybody that knows me forgets I've even got just one eye. And I was talking to some people, I work in a high school with teenagers, and the way I deal with it is the teenagers will say, what have you done to your eye, miss? And I just say, I've had cancer, I've had my eye removed, and that's it. They never ask me again. If they hear anybody else asking what it is, they'll go, do you realise Miss has had her eye removed because she's got cancer? Don't you dare say anything. So they're proper protective of me. But it's lovely to see, because I work in a really, really, sorry, probably shouldn't say it, but I work in a really rough area with a lot of drugs and alcohol students, the parents, not the students, but the parents. And so the kids come from very tough backgrounds, and they are the most caring and supportive students I've ever had. I had some kid come straight up to me, having a row with me, and all my class came right behind me, going, get away from Miss. So yeah, it is. So that's literally how I started. So, but after I had my eye removed, which I won't lie, wasn't good, and I had to have radiotherapy after that, where they gave me a mask. Now, a very good improvement. That's a recent mask I've just had done. I'll explain again. But it's the first one I had was like a Perspex one, and it didn't have the eye holes on. Now, my experience of having that mask done and having the radiotherapy was horrendous, and I had a aromatherapy lady came in and held my hand for the first one, which I have to say was amazing. And if that's anything that we could bring in, if anybody is having to have a mask and they cannot see what's going on, to have somebody there just holding your hand saying the machines are moving, Deborah, they are putting wires across you now with this is what's happening, and you only need it for the first or second because then you know what's happening. But they did it to me when I had this one, but the first one, which I say is 14 years ago, which is great to show how much we have come on with empathy and how the staff are with me now, which is brilliant. Sorry, tell me if I'm waffling as well. So after I had my eye removed, I thought I would be okay. Unfortunately, I found another melanoma in the back of my leg. So we again had to have that removed, and again I had radiotherapy. 12 months, I like to go 12 months it seems, and then 12 months after that I started being unwell and we couldn't quite find it, so I had to keep having blood transfusions. I kept feeling terrible, but we couldn't find what was wrong with me until one day I started, well, to be honest, I was in work and one of the kids was throwing up. I came home, started throwing up, so I thought I'd caught whatever the kid at work had. Throwing up to the point where it was consistent. So my other half said we're getting an ambulance. So I ended up being rushed into hospital, and we had another melanoma in my intestine. They told me I might have to have a stoma because it was quite close to my bowel, but fortunately I didn't. So we got over that one. I was quite ill with it. We had to move quite a large portion of my intestine. And then we went for a scan after that, and I was told that I had it on, but it was nodules on my lungs and on my bowel. And they said it was like somebody had thrown sand at my lungs, which is how it was, is how I got it explained to me. So we started on a new, obviously Professor Lorigan said, we can't remove it because it's the way it is on you. So we're going to try a new drug called Nivolumab, which was up on there, wasn't it? I don't know whether I've said it right. But I went on that drug, and for 2 years, it shrunk and everything was great, wasn't it? I was absolutely fine. I was working, came in every 2 weeks, had it done. Absolutely brilliant. My life was back to normal. Unfortunately, after 2 years, I had a massive side effect. And I woke up one day in horrendous pain, and I was it was like I was wearing an elastic band suit. I was so tight. So we ended up back in hospital, and they said the drug had made my muscles, gave me something called myofasciitis, but it took a while for them to find out what it was, and it was just meant that it was as if I was laying in bed for 2 years and my body just hadn't been able to move. So we ended up getting all sorts of drugs to help me better. But one of the doctors did say to me, only recently actually, the fact that I had a side effect is one of the reasons I'm still here, because it meant it gave your body a kick start to start fighting the melanoma yourself. So I came off the drug, and I've been off the drug ever since. To be honest, I've not had any problems with the melanoma. The only problems I've had have been that when they took my eye out, they had to put plates in my head, and unfortunately, just over 12 months ago, they decided to make an appearance through the top of my head, which is on, am I right there? Can you see that picture there? So I was washing my hair and called Simon and going, what's this? And he said, I can see metal, we need to go in. Anyway, it seemed that the plates that were coming through, so I had to have the plates removed out the top of my head, and I don't know if you can see, I've got a nice big dint there on the side of my head, because they couldn't put the skull, they couldn't put any plates back in because my skull was so delicate and it was breaking up. So, which was fine. They gave me a nice rugby scrum helmet to wear all the time. As you can see, I wear it. But one of the girls at work has blinged it all up for me, and it's got all diamonds and everything on, but I still won't wear it. So I'm supposed to wear that, but I'm just really careful. And to be fair, in school, they're really, really good. I also, in the middle of COVID, I felt I was had pain shooting down my leg really badly, and I went to the doctors and they said, it's just your condition, take some more painkillers and take some more morphine. For about 2 weeks I was in absolute agony, walking around, going to work, until one day I went into work and I just couldn't put my foot on the ground. So they sent me home. I called Christie's and they went, you might have another melanoma, we're calling an ambulance for you now. Anyway, they took me into hospital and I'd broken my hip and I'd been walking on it. So they said, you've actually smashed your hip to pieces because you've been walking on it. So I had to have a full hip replacement. They aren't sure whether it was the radiotherapy that had caused it, or I've got osteoporosis from a lot of the steroids. So they think it's the osteoporosis, to be honest. So, and then, what are we on now? So 10 days ago, I think, might be, 10 days ago, I've had radiotherapy because from the radiotherapy that I had in my eye, it caused a tumour, so on my brain. So I had a brain tumour. So just 10 days ago, I've had radiotherapy, but just one blast of it, quite a strong one. And they said we can't remove it because the skin is too fragile, so we're just going to kill it and that will stop it growing. It's a very slow growing one. They are 99% certain it's not a melanoma because it grows very, very slowly, but they can't give me 100% because I was panicking then, saying as it started again. Now I hopefully we won't, and I panicked because I had such a bad reaction with Nivolumab, but obviously you've made so many developments since I had that, and Professor Lorigan put me at ease and said, do not worry, even if it has come back, there is something else we can put you on. So I'm sorry if I've waffled a little bit, but that was just a little bit about my experience. Now, one of the reasons I am here is I also do fundraising for the charity, and I do an eyeball every year. So I've done 7 eyeballs up to now, and this just on Saturday we raised £6,270. Thank you. And over the 7 eyeballs, we've raised over £40,000. Now, we gave some of that to the eye hospital, and we give some to Christie's, and we also gave it to Salford Royal. So between the 3 hospitals, and they've used it for basic equipment. Now, people have asked me, why do I do them? Because I wouldn't be here. I have a doctor, Dr. Roberts. Every time I go to see him, he always goes, this lady should be dead, which is great. I'm like, thank you. And also, I didn't realise when my eye doctor, Mr. Atala, gave a little bit of a speech at the eyeball, and he said, when we took Deborah's eye out, we thought we can give her 6 months to 2 years. And I never knew that. And I was going around to everyone, to my mum and dad, going, did you know that? And I went, yeah, well, we just didn't tell you. Did you know that? But 14 years has gone, and I am still here. And it's thanks to the medical team, which I cannot thank enough, which is why we do the balls. It's to all the staff involved. And I have to say, every single member of staff has been amazing with me, and over the years you can see how much has improved with patient care as well, and how people treat you has definitely improved. But I am here thanks to this wonderful man, is why I am still alive today, because melanoma, when you said right at the beginning, didn't it, I can't say it, the statistics weren't good, but I'm still here, which I have a lot to say thank you for. So.
Oh, thank you, Deborah.
Oh, sorry, it's not my mask. Sorry, that was my mask. So that's how they do them now.
Oh, thank you, and thanks for those kind words, and what you've said about the hospital as well. And I was talking to somebody outside, and I think we do try and treat people here as you know, I said patients are at the centre of everything we do, and that really is our ethos here. And we are looking at, we have a great hospital, we've got great facilities, we've got great staff. We've got a lot of staff who've been here for a long time because they don't want to work elsewhere. And I'm glad you were well treated, and it's how everyone should be, actually. It shouldn't be that, people need to comment on it. It should always be that it's expected. And you do really illustrate everything that Becky and I are talking about. On the one hand, the successes, and you're a shining example of that. But on the other hand, the risk of short and long-term side effects, which you've had both, you've had all the problems initially with the immunotherapy, and then more recently this, which is hopefully a benign growth, but due to the radiotherapy. And so it's very timely to pass over to Becky now to tell you a bit about where we're up to and where we go from here.
So thanks everyone, and really appreciate everyone coming today. So as Paul said, my name's Becky Lee, and what I'm hoping to show you over the next few slides is kind of what we're thinking in terms of where things are heading, and that's obviously a huge task, but hopefully I can give you a few vignettes of what we're doing. So first of all, really the whole team, and I say team as in all the scientists and people working, admin people, trials people working on melanoma, and we have really kind of three major focuses. The first is obviously we want patients to survive, and we want them to be melanoma free. And so we've got a number of different studies, and especially what I do in the lab in London, and for example what Carrie and Adam do that are in the audience today, trying to find novel targets which we can really kind of use potentially then in the clinic further along down the line. So we're hopefully finding the things today that will hopefully improve treatments in a few years' time. The other major focus, as Paul said, is that we want to tailor treatment to the patient. So we don't want to just give everyone everything. We want to actually say, well, what's right for you? And I'm going to give you some examples of tools that we can use to do that. And then finally, there's the aspect of, especially because now people are living longer with having had melanoma, is that we want not only for them to do well from the melanoma, but actually we want them to do well throughout their life following that, and to actually have a good quality of life that's long lasting. So I'm just going to give you a couple of highlights of some of the work that we're doing. So the first is looking at circulating tumour DNA, and that's a tool to understand cancer and also to direct care. And then I'll also discuss about the late effects of immune therapy in a study that we're about to open called Immune Tox. And so just to give you an idea of circulating tumour DNA, so this is DNA that actually comes from the tumour, which you can see there, which may be in any part of the body, but it goes into the bloodstream, and we're still trying to understand how that happens, but essentially we know that it goes into the bloodstream, and because it's DNA that comes from the cancer rather from the person, from the rest of the person, it's different to your normal DNA. So everyone obviously has cells made of DNA, but this is specific to the cancer. And that means that we can actually use it to understand a number of things about the cancer. So because it is different from the rest of your body DNA, we're able to detect it, and that means that we can say, oh, there's cancer there if we detect it. And so one of the examples I'll show you in a bit more detail is how we can use it to detect cancer early, and early melanoma, like melanoma coming back early. The other thing that we can use it for is to look at the levels of it in the blood, and that enables us to then look at how the cancer is responding to treatment. So if it's responding, the levels go down, and also when it's not working, then we can get an early idea of the fact that it's not working, and if the levels start to rise. And the other thing that we can do is actually, because of the amount of information it contains about the cancer, and because obviously it's really hard to biopsy every bit of someone's body, and it's a lot to do to go through those procedures, actually we can get a snapshot of what the cancer, how it's behaving and things like that, through some very kind of in-depth analysis of this DNA. And so I'm going to just give you a couple of examples where we've used this in the lab, and then actually we've now brought it to the clinic. And so this was some work actually from my PhD with Paul. So the first is how can we detect melanoma relapse? So obviously there's a lot of people that have the surgery of their melanoma either from the skin or from the lymph nodes. And then they basically get followed up. Now we can offer them some treatment, but essentially we don't know at that exact time whether the melanoma is still there or not. Obviously we can try and see over time with scans, but we don't know at that exact time point. So what we did was following the patient's surgery, which you can see there with the knife, we took a blood test within 12 weeks of that surgery. And then what we did was we went into the lab and we tested to see whether we could find this DNA coming from the cancer cells. And there were some patients that had detectable DNA, so a small number of about 15% of patients. We were able to find this DNA from the cancer. And then the rest of the patients, we couldn't find the DNA. And when we looked at those patients, we then looked at kind of what happened to them in the future. And when we did that, you can see this is a similar curve to what Paul showed you before. We were able to see that in the pink line there with the detectable ctDNA, you can see that patients actually, every drop down of that curve is unfortunately a patient dying. And so you can see that more patients died if we were able to detect the ctDNA. And essentially what we learnt from this study was that actually if we were able to detect the cancer, that meant it was still there. It was really specific for the cancer. And so the patients, unfortunately, this was a long time ago, so it was before a lot of our new treatments. Unfortunately, because of that, they then ended up dying from the melanoma, and so their lives were reduced. But it enabled us to say, well, now we have a test where we can actually say we think that the cancer's still there, even though we've taken the majority of it out with surgery. And also, if we then, we did some follow-on studies, and if we do regular blood tests, we're able to pick up more of the patients as the melanoma comes back. So that enables us to really have a really very kind of specific test, but also a sensitive test, better than a scan. So this is all patients without any evidence of melanoma on a scan, that we can then say, well, what can we do? Can we do something to try and prevent that melanoma coming back on scan? And so based on this work, we've now designed and is about to open a clinical trial called Detection. And initially it's just a feasibility study to see whether we can do it, but we're hoping to then do a much larger study. And that's where we take patients that are early stage, so low risk melanoma. So those are patients that have just got the melanoma in the skin or just may have travelled a bit to a lymph node. And now we actually, after surgery, are offering those patients a year of immune therapy, and that's our standard of care. But that again is that treat all approach, which we want to treat the people that really need it. And the reason for that is the side effects, as you've heard, of these medications. But also, it's a year of treatment, and there's a lot going on. So what we thought was, can we use the blood test to actually define who really needs this treatment? And so what we're doing is comparing having the regular blood test and then testing it for that ctDNA, whether it's present. If we are able to detect it, then we give the patients a treatment, and we give the best treatment that we can give, which may be 2-drug treatment. And so And so we think that hopefully using this blood test, we can actually direct patients' care so that people who really need the drugs get the drugs, and it's at a really early stage where we can't see the cancer on a scan, which we think should be very beneficial for actually getting on top of the cancer and preventing it come back. But then we spare patients from side effects of treatment. And so that's about to open. So one of the other things that we're doing is trying to make decisions about patients' treatment based on that level of the circulating tumour DNA. And so we currently give to patients that have got a BRAF mutation, so that's patients that have got something gone wrong in the cancer cells, these targeted therapy, and that basically stops the melanoma growing and surviving and kills the cancer cells. Now, when we give this initially, if the cancer is responding, then what happens is you get a hot tumour with lots of immune cells coming into the cancer, which is a good thing and potentially could actually be good for immune therapy treatment. However, if the cancer becomes resistant to the targeted therapy, the tumour becomes cold, and so all the immune cells go out of the tumour. And so that actually makes it really much harder to give the immune therapy and for it to actually work. And so there seems to be a sweet spot in the cancer that means that basically if you give some initial targeted therapy, you could actually hopefully improve responses to the immune therapy. But if it's resistant, then it won't work. And so we're thinking, can we use that circulating tumour DNA to guide the treatment? And so what we did was we set up a clinical trial, and it was some of the money from the Christie charity went towards that trial, and it was called Cactus, which you can see the little logo there. And basically what we were able to show, and this is just an example, was that we were able to use the circulating tumour DNA to help make a decision. And we could do that in real time in patients coming to the clinic. We get their bloods, we analyse it in the lab, we give the result within 7 days. Then we make a decision about what we should do with their treatment, and all of that process, which is it's quite a big effort from many people to set up. But actually, we showed in this trial that we're able to do this now. So, and I think that's going to really help maybe further trials down the line. And this is just an example of one of the patients on the study, and so you can see here that initially they had quite a high level of circulating tumour DNA. We gave the targeted therapy and the level dropped, so this was their next blood test. And then based on that blood test, we got the result back so quickly and then made a decision and switched their treatment over to immune therapy. We started giving the immune therapy and they had a really good response to it, and you can see that over the course of all their time the circulating tumour DNA level went to 0, and in fact that was the same as what we saw on the scan, so we had a complete response on the scan, and in fact the patient now is I think almost 2 years following that initial treatment and are doing really well, and we can't see any evidence of active melanoma on their scans. And so this really shows you kind of the potential for this blood test in the way that we can look at responses, but actually if the patient had got a rise in this level at any time, that would be an early indication of the cancer becoming more active, and we potentially could then think about a new trial where we might treat early and try and get on top of it again with maybe a different treatment. So those are the kinds of things that we're thinking about using this very specific blood test for. And so I'm going to just completely switch tack and just talk to you a little bit about a new study that we're just about to set up, which again has been funded by the Christie charity. So as Paul has said, treatments significantly improved survival for patients with melanoma, and we're using these treatments at a much earlier stage now. So that means that there's a huge number of patients that are getting these treatments that actually will then have to live with the consequences of those treatments, and actually not have any consequence from melanoma but from the treatment. And Deborah's talked to you about some of her experiences, and this just shows you some of the side effects of these treatments. It's a very, a lot, and I think that's the major message that I want to take to give you. It can affect any body system. It doesn't mean that you're going to get any of them if you're on the treatment, but these are the potential ones that people can get, and they don't necessarily get all of them as well, often just one or two. But some of these can obviously be very serious, and some of them can be lifelong. So for instance, the effect on the hormone gland, people will need to take medication for the rest of their lives for that. So, and we know in great detail the side effects of these at the time of giving treatment and kind of for a few years after. But what we don't know at the minute is the kind of late effects of these treatments. So we don't know what the effect is down the line, and there is a possibility that there might be a bit of low-grade inflammation going on, just because of the way these treatments boost up the immune system. And there's some early data to suggest that it could potentially affect the heart and the cardiovascular system. But we don't know for sure at all. It could be that people are just absolutely fine and we don't need to worry about it. But what we felt was that actually, because we're giving so many of these drugs now, we really need to understand better, because potentially we can prevent issues down the line for people. And so we developed the immune tox study, and that's asking some of these questions. So, are the side effects that occur later down the line, and what are the chronic and long-lasting side effects, how they interact with other health problems people might have, and who is at more risk of developing those issues, so that hopefully we can come in with a treatment that might be just, do more exercise and things like that. But it's important to know what you should be doing, so that hopefully people can have a long-lasting and also good quality of life. And so just to give you an overview of the study, so we've got a group which we call our control patients who haven't had any of these drugs but have had melanoma, a group that have had the immune therapy treatment a couple of years ago, and then a group who are just starting their immune therapy treatment. And we're going to follow these patients for at least 6 years, hopefully a bit longer than that. And we'll be doing examinations, asking them if they've got any new health conditions, checking their cognition, so testing whether there's any early signs of dementia, for instance, and then looking at their quality of life through questionnaires. So that just gives you an overview of one of the new studies that we're doing. So just in conclusion, as we've all said, melanoma's significantly improved the outcomes, the treatment for melanoma, and we now have potential strategies to improve the response and prevent resistance to the treatments, and we're working on that in the lab. The circulating tumour DNA blood test is really useful as a tool for the clinic to try and make decisions, and we're testing whether actually it's useful in terms of improving outcomes for patients, and also we can also think about longer term survival of patients with melanoma and their quality of life over a number of years ahead, just because that's important as well as just the immediate melanoma issue. So with that, I'd like to thank you all for listening.
Thank you, Deborah. Thank you, Paul. Thank you, Becky. And thank you, everybody, for joining us for this event. We We'll be running the next in the rejuvenated series in September. There's still a bit of friendly competition, I think, amongst teams as to exactly what the topic of that one will be, but we'll be posting that online and letting you all know about that in due course. And please do just thank all of our speakers with me for this morning. Thank you.